Good day everyone. I'm going to present the article entitled Ethical Stress, Virtues and Values, Conflict in Pediatric Death by Stephanie Kukura, Naomi Lavinthal, Patricia Kiefer, and Janice Firm. So let us define first what is virtue. A virtue is thought to be a good character trait, conformity to a standard of right, a particular moral excellence. So in medical term or in medical practice, virtue is a trait of character that disposes a person habitually to excellence of intent and performance with respect to the proper of life as human being or to a specific activity or role in life. Some virtues such as cleanliness are important socially rather than morally. So, virtues promotes happiness, our own as well as that of others. This is a very nearable theme in philosophy, religion, and moral education, although it is often contested. So what is values? Values defined in organizational behavior as the collective conceptions of what is considered good, desirable, and proper or bad, undesirable, and improper in a culture. So in medical practice, it refers to the respect for human dignity, respect for self-determination and autonomy, the primacy of patient welfare, the principle of non-injury, and solidarity. So values may be specific, such as honoring one's parents or owning a home, or they may be more general, such as health, love, and democracy. So this is the background of the study of the article. So ethically challenging situations arise in providing care for critically ill and dying patients. While death occurs far less frequently among neonatal and pediatric patients than adult patients, the emotional impact of witnessing the death of a patient is greatly amplified if that patient is an infant or child. Providers who participate in caring for these patients and their families may suffer psychological harm stemming from moral dilemmas and distress. The consequences of repeated exposure to these types of ethical stressors can lead to significant burnout and compassion fatigue, affecting not only the mental health of the provider but also compromising the care they give to patients. So, hospital institutional ethics committees or IECs provide ethics support at an institutional level and should, in principle, reinforce basic ethics education provided in most training programs for health professions. Their role includes resolving conflicts surrounding patients' treatment decisions through clinical case consultations, offering a forum for discussions of policies involving institutional ethics, and providing education about ethical to their healthcare communities. So, care providers of critically ill pediatric patients encounter ethically complex and morally distressing situations in their practice. Though many providers receive an introduction to ethics during training, the retention and application of ethical principles to daily clinical practice may be limited. Furthermore, current approaches to clinical ethics consultation focus on specific problems of individual patients and may not meet the emotional and debriefing needs of providers. So, the objectives: to identify whether the provider's remark on ethical conflicts or note moral distress without being specifically prompted when asked to share thoughts, comments, questions about recent in-hospital pediatric death and to characterize the nature of these conflicts and distress. For the methodology, constructivist thematic analysis of free text survey responses was used to explore whether providers remarked on ethical conflicts or noted moral distress without prompting after the death of a patient for whom they had provided care. This project was exempt from review by the Michigan Medicine Institutional Review Board as a part of an ongoing quality improvement effort. Sample and recruitment. Survey respondents were interprofessional care providers at a 348-bed pediatric academic medical center in the state of Michigan. All providers, or N is equal to 2,701, who cared for a patient less than 18 years of age within the 24-hour period leading up to his or her death were identified via the electronic medical record. Participation was voluntary. Responses were anonymous as to specific participant identified. Although the survey did request information about the role on the provider team and unit in which care was provided. Results. Participant characteristics. There were 880 surveys completed out of 2,701 emailed to providers identified by the medical record as having participated in a pediatric patient's care in the 24 hours preceding that patient's death, or 33% total response rate. At least one completed survey was returned for 165 of the 168 deaths occurring between November 2014 and May 2016, or 99.4% of deaths. There were 306 or 35% of completed surveys, free text responses, and at least one free text comment was made regarding the deaths of 138 pediatric patients, or 81% of in-hospital pediatric deaths that occurred in that time period. So, 52 respondents described ethical challenges surrounding their patients' deaths, corresponding to 17% of those providing free text responses, and 6% of all survey respondents. Comments regarding ethical conflicts were identified for 38 unique patient deaths, or 23% of all pediatric deaths, with 2 patients receiving comments from 3 individuals and 8 receiving comments from 2. Diverse provider rules were presented in Table 2, caring for patients who died in multiple hospital in units in Table 3. So in conclusion, many providers experience ethical conflicts with pediatric end-of-life care but may not be able or willing to share this candidly. Targeted education to assist hospital staff in identifying and resolving ethical conflicts encountered in pediatric end-of-life care, and further ethical support for providers to share or debrief safely without criticism or negative repercussions may be warranted. Future directions and implications for practice. Based on these findings, additional exploration of the ethical challenges faced by pediatric providers during end-of-life care is needed. Further inquiry of all members of the interprofessional care team as well as of patient's family will better inform educational efforts for providers and improve patient care in these medically, emotionally, and ethically complex cases. Further investigation of the frequency and nature of ethical concerns and ethical stress following pediatric death, as well as the consequences for providers of experiencing it, is warranted. Trial and evaluation of prospective interprofessional ethics, education, and support is high mortality pediatric inpatients units may also be valuable in identifying ways to mitigate ethical stress for providers or of pediatric end-of-life care.